Welcome to a webinar Beyond the Basics and into complex topics in expanded carrier screening. I am Sarah Ramaya, Curriculum Designer at ASRM. This webinar is presented by the American Society for Reproductive Medicine in collaboration with the Genetics Counseling Professional Group. This webinar was developed by the American Society for Reproductive Medicine as an educational resource in service to its members and other practicing clinicians. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. Please note, all attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the question chat window at any time. We will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. The moderator of today's webinar is Andria Besser. Andria is a board-certified genetic counselor and director of reproductive genetics at the NYU Langone Fertility Center. She obtained her master's in genetic counseling at Mount Sinai School of Medicine and has been specializing in assisted reproductive technologies for over 10 years. She is a past chair of the National Society of Genetic Counselors, Art and Fertility SIG, and an active member of the ASRM Genetic Counseling Professional Group and the Patient Education Committee. I'm now going to turn the presentation over to Andria to introduce today's speakers.
Thank you, Sarah. So as mentioned, we're going to be talking about complex topics in expanded carrier screening. You can go to the next slide. So our speakers today, we have Lauren Isley, who's a clinical science liaison at Generate Life Sciences. She received her master's degree in genetic counseling from Wayne State University. Lauren has focused on assisted reproductive technologies for the majority of her career, including pre-implantation genetic testing and gamete donor screening. She's the current chair of the Genetic Counseling Professional Group of ASRM. Another speaker is going to be Amy Vance, who's a board-certified and licensed genetic counselor and founder of Bay Area Genetic Counseling, a consulting practice specializing in genetic risk assessment for gamete donors and fertility patients. Amy earned her BA in zoology from Miami University in Oxford, Ohio, and her master's in genetic counseling from the University of Cincinnati. Her area of interest and research was focused on the importance of family history risk assessment for gamete donors and couples prior to IVF. And our last speaker is Jamie Dachson, who's a multi-state licensed and certified genetic counselor with over a decade of clinical experience in reproductive medicine. Jamie received her undergrad degree from Brown University and her master's from Johns Hopkins. She's the founder of a private practice, Navigate Genetic Counseling, which is a telegenetics practice working with clinics and individual patients requiring genetic counseling services. So our agenda today, we're going to start off talking about the history of carrier screening and review the professional guidelines around carrier screening. Then we'll move into discussing more challenging carrier screening results. We'll have a discussion about how to read the carrier screening report and especially some of those more complex results, and then we'll end off with a panel Q&A. So I'm going to hand it over to Lauren, who's our first speaker.
All right, thank you, Andria. So as Andria mentioned, my name is Lauren Isley, and I think in diving into some of these more nuanced topics surrounding carrier screening and some of these complex cases, I think it's important to have a good baseline on how far we've come with carrier screening and where the professional guidelines stand today. So what's the purpose of carrier screening? So the whole idea behind carrier screening is the identification of individuals who carry a mutation for an X-linked or recessive disorder. In recessive inheritance, which is represented here on the left-hand side of the screen, individuals who carry a mutation for a recessive disorder If their partner carries a mutation in the same gene, that couple is at a 25% risk, or 1 in 4 risk, of having a offspring who is affected with that disorder. This is represented by the classic Punnett Square, where a capital A represents a normal or a wild type allele or gene, and then the lowercase a represents a copy of the gene with a mutation. So if you have 2 parents who are carriers with a big A and a little a, you can see there's a 25% chance they'll have a child who is a non-carrier, a 50% chance they'll have a child who's a carrier, a big A and little a, just like they are, and then again a 25% chance that the child would inherit both little a mutations and be affected with the disorder. In X-linked inheritance, these are typically scenarios where the female carries a mutation in a gene on the X chromosome. When that female goes to have a child, there is a 50% chance that she will pass down that X chromosome with the mutation. So essentially, all of her children have a 50% chance of inheriting that mutation. If she has a daughter and that daughter inherits that mutation, the daughter would also be a carrier for that X-linked condition, although we know that females can certainly manifest symptoms of X-linked disorders as well. And then if she has a son and she passes down that mutation on the X chromosome, because the son does not have a second X chromosome to compensate for the other, that son would be affected with that X-linked disorder. So sometimes, but not all of the time, females are carriers for X-linked disorders and males are affected. In X-linked inheritance, testing the partner generally does not matter. It would generally only be one member of the couple that needs to be tested. And then the whole goal, of course, behind carrier screening is really to help inform people about the risk of having children with autosomal recessive and X-linked disorders to allow for informed decision-making about reproductive options. I think that's a really important take-home message. The point is to provide education so patients can make informed decisions. We've really come a long way with carrier screening since the 1970s. So back in 1973, carrier screening for a condition called Tay-Sachs disease first became available, and it was done via enzyme analysis back then, and it's still widely done via enzyme analysis today. And at the time, this was a major public health initiative which the Jewish community widely embraced. And because of that, it was very successful, and it drastically reduced the incidence of babies with Tay-Sachs disease. Fast forward another 20 plus years, and the gene for cystic fibrosis, the CFTR gene, was discovered in the early 90s. And in 1997, the NIH published a recommendation or a statement that recommended cystic fibrosis carrier screening. ACOG came out with their first recommendations for CF carrier screening, but actually screening Caucasians and Ashkenazi Jewish individuals was only recommended at that time because those were considered to be the high-risk populations for cystic fibrosis. However, just 4 years later in 2005, ACOG published new guidelines recommending pan-ethnic carrier screening for cystic fibrosis. In 2008, the ACMG recommended carrier screening for spinal muscular atrophy, or SMA. At that time, ACOG actually did not recommend carrier screening for SMA. This came later on, as we'll see. Around 2008 or so, there was sort of a shift in technology, and the cost of genetic testing drastically dropped. So it actually became more cost-effective to test for multiple genes on one platform. And right around that time, both ACOG and ACMG issued recommendations for carrier screening for Ashkenazi Jewish individuals for a handful of conditions. And then in 2017, ACOG actually met ACMG's recommendations of pan-ethnic carrier screening for spinal muscular atrophy, stating that all women who are considering a pregnancy or planning a pregnancy should have carrier screening for SMA. And in that same year, ACOG actually also published recommendations surrounding expanded carrier screening, which we'll talk about in just a couple of slides. So these are really the take-home messages in terms of how far we've come with carrier screening. Again, carrier screening really started out as being offered to patients based on family history or ethnic background. Again, Tay-Sachs disease is a good example of this, being screened for in the Ashkenazi Jewish community. There are other conditions that have this founder effect where there are known, well-established mutations in that specific ethnic group that sort of propagated through time, just based on people having children within a small ethnic group or a small population. And then hemoglobin disorders are another example of this, where carrier screening for hemoglobin disorders is primarily based on ethnic background. And then cystic fibrosis, as we noted from the timeline, really was the condition that sort of started this pan-ethnic screening model, where it was recommended that individuals of any ethnicity should undergo carrier screening for CF. So coming to where we are now today with professional guidelines versus industry-based or sort of industry, what is going on in the industry now. Again, just to recap from our timeline, cystic fibrosis and spinal muscular atrophy are recommended for all ethnicities. For hemoglobin disorders, and this is a recommendation from ACOG, this is still primarily an ethnicity-based recommendation. So essentially the recommendation is to perform a complete blood count on all women who are currently pregnant to assess for anemia and the risk for a hemoglobin disorder. And if that CBC indicates a low MCV or MCH, or that individual is of a high risk ethnicity, then a hemoglobin electrophoresis should also be performed. So this would include individuals of African, Mediterranean, Middle Eastern, Southeast Asian, or West Indian descent. There are a handful of conditions that are recommended to be screened for in individuals of Ashkenazi Jewish ancestry. We've talked about Tay-Sachs disease several times. Other conditions include Canavan disease, familial dysautonomia, Bloom syndrome, Fanconi anemia type C, Niemann-Pick type A, mucolipidosis type 4, and Gaucher disease. That list may be even larger depending on who you talk to, but those are typically the conditions that we think about most often. And then Fragile X syndrome. So Fragile X is an X-linked condition, is the most common inherited form of intellectual disability and autism spectrum disorder. Carrier screening for Fragile X is recommended for women with a family history of Fragile X-related disorders or a personal history of unexplained ovarian insufficiency or failure. So this is what currently exists today in terms of professional guidelines. As many of us know, what is happening in the industry, both preconception and prenatally, is not necessarily based on what professional guidelines say. Much of the industry has moved to an expanded carrier screening model. So in expanded carrier screening, the size of these panels varies widely. For some labs, the panel may be 1 to 200 diseases. For some laboratories, the panel may be upwards of 500 conditions. The panel makeup is mostly laboratory and industry driven. And basically what this means is that laboratories have their own discretion in terms of what conditions they want to add to their panel and how large they want their panel to be. And many laboratories will essentially make decisions based on the size and the makeup of their panel based on what other laboratories are offering at that particular time. many of these laboratories do have genetic counselors and trained genetics professionals on staff to help make those decisions and to help laboratories understand certain conditions that maybe should or should not be included on a panel. And as already pointed out, these panels really are not guidelines driven or ethnicity based, but some laboratories may have the option to customize panels, meaning if a provider only wants to order testing for conditions which are recommended by ACOG or ACMG, that provider may have the discretion to do so based on the particular laboratory that they're working with. And both ACMG and ACOG do have essentially professional guidelines that say, here's some general guidance on what should and shouldn't be included on an expanded carrier screening panel. A lot of these criteria really do overlap. A few common themes are a high enough carrier frequency. There's sort of been an arbitrary carrier frequency of about 1 in 100 or 1%. If at least that portion of the population is expected to be a carrier, that would be appropriate for inclusion on an ECS panel, although those guidelines do not stipulate which ethnicity that 1 in 100 carrier frequency must be in, or whether it's a pan-ethnic or worldwide carrier frequency that they're basing that off of. The condition must have a well-defined phenotype, so we know that individuals with mutations in this gene will have these types of symptoms or medical issues or present in this specific way. These guidelines both state that these conditions generally should be severe conditions that have a significant impact on quality of life and may cause cognitive or physical impairment, and may require surgical or medical intervention. So sort of the idea behind that is conditions for which parents would at least consider prenatal diagnosis. In addition, testing for conditions with variable expressivity or incomplete penetrance, or those with a mild phenotype, should be optional. Finally, there is a recommendation that adult onset disorders included on an ECS panel should require specific consent to screening. But as we'll see with some of the case examples being presented today, I think this is a really big gray area in terms of what constitutes an adult onset or a dominant disorder on a carrier screening panel. And so with that, I'm going to go ahead and turn it over to Amy.
Hi, okay, so I'm going to be talking about challenging carrier screening results today. So some of the things I'm going to be touching on are mild conditions or low penetrance alleles, manifesting carriers both for patients and donors, and quote, affected patients or patients that are identified as being homozygous or compound heterozygous for a recessive condition, or males that are hemizygous for an X-linked condition. And so when you think back about your own carrier screening program in your clinic, you should be seeing these kinds of test results relatively frequently. And if you're not, it might be helpful after maybe this webinar to go back and look at your carrier screening results and make sure that you know where these types of sentences or where this type of information is located so that you're not overlooking these kinds of results. So I'm going to use GJB2 as an example for a few slides, because this is a gene with high variability among the different variants, and also can have low penetrance alleles. So GJB2 is a gene that's associated with non-syndromic hearing loss. Variants in this gene are very common. Maybe 1 out of every 43 people is a carrier. I see carriers for this gene every single week. Different variants are associated with different severities of hearing loss, and it follows autosomal recessive inheritance, which Lauren reviewed. So it's important to read your carrier screening test results carefully. The amount of detail about different variants varies among labs. For some labs, you might have to inquire about what we call variant curation. And so what variant curation is, it just means what kind of severity the particular mutation in question is associated with. And so I'm showing you just a representative example in the small print. You don't have to read all of that, but that's what the variant curation section looks like on the reports that I use. And so the sentence that is of significance is, it states that this particular mutation has low penetrance, is reported in individuals with mild to moderate hearing loss, and segregates with hearing loss in families. So it's important to know where this information is on the lab's report that you use and how to interpret it to properly counsel your patient. It's usually not on the first page. The first page will give you information about whatever the person is a carrier for. There will be some information about what the particular condition is, many paragraphs. Within those paragraphs, there might be a little bit of information about the severity that is associated with your variant, but some labs include further detail, maybe on page 4 or 5. And for couples that are at risk to have an affected child, I believe that proper counseling really involves additional reading and a deeper discussion of the natural history of the disease and specific variants that are involved, including data for the possible outcome. And the information on the report may not, and usually for me, is not enough. And the lab that I use, and probably the labs that you use, also provide PubMed IDs and different articles that you can read further about before counseling an at-risk couple. So this is just to give an example of one point of the extreme variability among variants for this gene and for some other genes. For GJB2, hearing loss can range from no detectable hearing loss at all to profound deafness, even within people that have the same genetic makeup or genotype. So my example, I'm using the capital A as the recessive allele. Sorry about that. Lauren used the capital A as the normal allele. I'm using it as the gene mutation. And so these two carrier parents on top are both carriers for GJB2. They have mutation capital A. They have 4 children. 2 of their children are deaf. Their children both have the variants capital A, but the son has mild hearing loss and the daughter has profound hearing loss. And so this gene, along with many other genes, represent complex counseling situations, really requiring detailed information to be provided to patients in an understandable way so that they can make important decisions about PGTM. So some of the points that I would cover during a genetic counseling session like this, I'm using an example of a couple that presented to me about 6 weeks ago for counseling pre-IVF. Both of them were carriers for the variant V371. You've probably all seen this variant. It's very, very common. It's a low penetrance variant. And so what I do is I review studies. There are many studies on this particular variant. One study, I'll just give you an example, looked at 57 people that were homozygous for the V371 variant, so exactly like my couple. And then I would talk about the outcomes. The outcomes include 53% of people within this particular study having mild hearing loss, 26% having moderate hearing loss, 8% having severe hearing loss, and 13% having profound hearing loss. And so you can see the difficulty in decision-making for a couple when they have this wide range of possible outcomes and we cannot predict the outcome for the particular patient in front of us. It's mainly data. So I also discuss available treatments that are related to deafness, such as hearing aids, educational adjustments, cochlear implants, a discussion of the couple's feeling toward the possibility of having a deaf child, a discussion of PGT-M versus newborn hearing screening. The couple ultimately decided not to screen their embryos. But the other thing I talk to people about is anecdotal information, such as within my own practice in the last year, I've probably seen 3 different individuals on routine carrier screening without deafness that were identified as homozygous for this particular variant. And so these people are actually missing from the published data, because all of the published data really looks at individuals that are identified because of their hearing loss. And so these numbers are really an overestimation of risk. And so it's just a piece of information that I talk to this couple about, and I talk to patients about, and sometimes that type of experience can be helpful for patients making these decisions. So other low penetrance alleles that you might be familiar with include the Hfe gene, which is for hereditary hemochromatosis. This is an adult onset condition in which only about 2% of individuals that have 2 mutations actually have any symptoms. It's also treatable with phlebotomy. The GALT gene, which is the gene for galactosemia, there's a variant called the Duarte variant. By far, this is the most common mutation that we see. And homozygous status does not cause any disease. The reason that it's reported is because it can skew the newborn screening results, but PGT-M is not indicated. And then there is silent carrier status for alpha thalassemia, which people get very confused about. I'm not going to spend a ton of time describing thalassemia, but some important points are this is the most common test result that we get for alpha thalassemia. The alpha globin, there are 4 alpha globin genes, 2 on each chromosome, and so that would look like AA/AA. Silent carriers have a deletion of 1 gene. A person can have a deletion of 1 gene, 2 genes, 3 genes, or all 4 genes. A deletion of all 4 genes is alpha thalassemia major, and that's really the main thing that we care about with this screening. So silent carrier status, if both people are silent carriers, they are not at risk for offspring with alpha thalassemia major because they only have a single gene deletion. Their highest risk for a couple like that would be A and then minus, A and then minus, which is thalassemia trait, which is a 2 gene deletion, and the deletions are what we call in trans. In trans means they're on 2 opposite chromosomes. In cis means they're on the same chromosome. And only couples who have thalassemia trait in cis would be at risk for alpha thalassemia major. Okay, so another complicated category is what we call manifesting carriers, or the lab that I use calls these personal risk genes. And so out of a panel of maybe 300 genes, there are actually 62 of these personal risk genes in which carriers are at risk for symptoms. And so just some kinds of, just examples of what kinds of things we're talking about. It could be cancer predisposition. It could be something called hypodontia, which is missing teeth. Cardiomyopathy, which is associated with the Duchenne muscular dystrophy gene, respiratory symptoms and pancreatitis, which is associated with CFTR, which is a cystic fibrosis gene, Parkinson's disease, and Lewy body dementia, which is associated with GBA, which is the Gaucher's gene. And so the confusing thing is that genes in which carriers can manifest symptoms, they act like they're dominant. So there's a 50% risk for the offspring to inherit the variant and potentially manifest symptoms. And this has special implications for gamete donors because the ASRM guidelines say that donors should not be carriers for an autosomal dominant condition, but they also say, they say if there is a situation where recessive carriers can manifest symptoms, these donors should be considered on a case-by-case basis with genetic counseling. There also may be on these lab reports, these carrier screening reports, there may be a statement that recommends either a clinical evaluation or some type of medical follow-up for the patient. And so you should be documenting that that has been offered. So we can talk about an example of this. I had a female patient about 2 months ago come to the IVF clinic for just a routine IVF cycle. She was using a sperm donor. Routine carrier screening revealed that she was a carrier for something called Fabry disease, which is an X-linked lysosomal disorder. So as Lauren talked about, the general rule is that females are carriers, but honestly, when it comes to genetics, every rule has an exception. And the exception to the X-linked carrier status is that some carriers can manifest symptoms because of skewed X inactivation. So there are different forms of Fabry disease. There's a classic form, which affects males, is childhood onset, involves severe pain crises, sweating abnormalities, vision loss, and end-stage renal disease. Usually occurs between the ages of 30 and 50 in males. Most males also have cardiac disease. Then there's a variant form which affects males. There's a particular cardiac variant which has later onset between age 60 and 80, cardiomyopathy, but not end-stage renal disease. There's a renal variant which does involve end-stage renal disease, but no skin lesions or pain. And there's a cerebrovascular disease variant which presents with stroke. And then there are heterozygous females which can be affected. They typically have milder symptoms and are affected at a later age. However, again, the exception to every rule is that rarely they can have either no symptoms or they can be affected as severely as a male with the classic disease. So again, it's important to recognize the variability of many genetic conditions and to tie your genetic counseling to the particular variant that your patient has. So the discussion that I had with this woman was that her variant was associated with the cardiac type of disease. And so what I read in an outside study was that in some female heterozygotes, even that don't have cardiomyopathy, there can be severe and irreversible cardiac damage that can occur before the development of cardiomyopathy, highlighting the importance of early diagnosis and screening. So I referred her to a cardiologist to screen for any type of cardiac symptoms that she might have and to make a follow-up plan for her future medical management, as well as anything that could be pertinent for her IVF treatment. We talked about the possibility of PGTA for gender or PGTM for the exact mutation. We talked about the fact that she should talk to her family members about her test results so that they could be offered screening. She ended up choosing PGTA for sex selection of female embryos, even though she understood that females could have symptoms. And then 2 weeks later, we talked again and she changed her mind and decided to do PGTM. So this is my last slide, and I just wanted to touch on some logistical considerations for carrier screening. Consider concurrent screening. Concurrent screening means that you screen both patients at the same time. There's a lot of clinics that screen one person, and if they're negative, they don't screen the other partner. And to me, that logic is flawed. I had a case about 3 months ago in which there was some type of a glitch with the carrier screening. The male was screened and there was some type of delay with the female's result. The male's test result was negative. They said it was fine. They went ahead and created embryos. PGTA was done and the embryos were frozen. We got the female's results back and she was a carrier for a premutation for Fragile X. So clearly, not a great situation. The couple, after genetic counseling, decided to thaw and test their embryos. A second point is to consider screening males for X-linked conditions. There are conditions in which males can be affected, but they're unaware because of a later onset. I had a patient that was diagnosed with OTC deficiency, which is a urea cycle disorder on routine carrier screening. He had ended up having a variant that was late onset type, which can include migraine, nausea, ataxia, and blurred vision. For him, all of his female offspring would be carriers. No males would inherit this gene because, of course, they inherit his Y chromosome, but 20% of females can have symptoms. So it could still affect his decision-making about PGTM. And he was also referred to a clinical geneticist for evaluation and possible treatment based on this disorder. Consider informing people that these more uncommon types of test results that could affect their own health can occur prior to screening them. Standard lab consent forms do not include information about these conditions. So you would have to add a statement to your consent form. And consults regarding complex carrier screening results may best be provided by a board-certified genetic counselor. So I'm going to pass this over to Jamie now.
Okay, sorry, I was on mute for a second. Thank you, Amy. I'm going to jump off by just kind of piggybacking on what Amy was going over, but just talking about some different kinds of carrier screening results that are not so simple to understand, that are complex and can often require some additional genetic investigation beyond what's on your initial genetics report. So some red flags that you could see on some genetics carrier screening in your patients that sort of alert you that these are going to be a little trickier and may require some additional interpretation. I'm going to talk about why it's important to read the fine print in the interpretation section, which Amy already touched on. And specifically, I'm going to talk about patients who come back as an unlikely carrier. I'll talk about that in the context of 21-hydroxylase deficiency, and when patients come back as increased risk carrier, which we can see with several disorders, but commonly see with spinal muscular atrophy. And we'll talk about how the screening results can be discrepant with each other, and I'll give an example how the DNA and Tay-Sachs enzymes results were discrepant in my patient. So just a very brief review of congenital adrenal hyperplasia. This is a group of disorders affecting how the adrenal glands work. And with this type, there are different types. With 21-hydroxylase deficiency, a missing enzyme can lead to overproduction of specific hormones that are made by adrenal glands. There are two main forms of this condition. There's classic CAH and non-classic. And classic is much more serious. This can cause virilization in female infants. They may be born with ambiguous genitalia. Both sexes can have salt wasting crisis, which is an excessive loss of salt in the urine and can be very serious or even life-threatening. Non-classic 21-hydroxylase deficiency is much milder. It's typically not identified at birth or shortly after. Usually it's identified a little bit later, but still has some different hormonal implications, can cause early puberty, short stature in adults, and decreased fertility. The gene that's involved in 21-hydroxylase deficiency is called the CYP21A2 gene, and whether or not a child would be at risk for classic 21-hydroxylase deficiency or non-classic is dependent upon the specific variants that the parents carry in that gene. And that's usually called out on your carrier screening results. When it says patient is a carrier of 21-hydroxylase deficiency, it'll also later, maybe on the second page, indicate that this particular variant is associated with classic 21-hydroxylase deficiency or non-classic. So I'm going to talk about a couple that I have. We're going to call them the Johnsons. The female, Jane, came back clearly with her carrier screening results showing that she was a carrier of 21-hydroxylase deficiency. But then the male, Joe, came back and it said unlikely carrier of 21-hydroxylase deficiency. And you'll see over to the right, actually a screenshot of what it said on the front page of the results. So the first kind of glance at this is, okay, they're both carriers. They both have something in bold with 21-hydroxylase deficiency. And is that concerning? Is there a need to go to PGTM testing? How do we counsel this couple? For this particular couple, they were not currently planning to do in vitro fertilization, so switching to an IVF with PGTM testing would be a very big switch. You'll see in the example on the right where they show what the actual results looked like on that front page, you'll see that they say unlikely carrier. You'll also see that there are 3 copies noted of the CYP21A2 gene, and you'll also see that they detected 1 specific mutation. So breaking it down, what does that mean that someone's an unlikely carrier? Well, we know that he has 3 copies of the CYP21A2 gene rather than the normal 2 copies. This is actually particularly fairly common with this particular gene that we see these duplications. We also know that 1 of those 3 copies has a mutation in it and can presume that the other 2 are normally functioning. What we don't know is how these 3 genes are distributed amongst the chromosomes. It is possible, if you look at situation number 1, it is possible that the mutation is on the same chromosome with another normal functioning copy of the gene, in which case this person really is not a carrier because both of their chromosomes have functioning copies of the gene. But it could also be situation number 2, where the 2 functioning copies are on the same chromosome together and the copy with the mutation is on its own on a different chromosome. And in that case, the individual would be a carrier. The reason that they say unlikely is that we do know that the particular mutation that this male had, we see it a lot in cis with another copy of the gene, but we certainly can't say that with certainty. So first question, does it matter? Well, the answer to that is, does it matter to your patient if you see unlikely carrier? The answer to that is really it matters what the reproductive partner is a carrier of. If the reproductive partner is negative for 21-CAH, then it's not that important. And I probably wouldn't do anything further in this case and would say, okay, you may or may not be a carrier, but your partner is negative, so we're not concerned risk the child. In this particular couple, it's extremely important because whether or not he's a carrier is the difference between whether or not their children are at risk. So how do we figure it out? What we can do in this case is do some parental testing. And by that, I mean testing of the male patient's parents. And sometimes that can be easier said than done. Parents may be difficult to locate. They may be deceased. So it's not always doable, but in some cases, by looking at the parents' copies of the CYP21A2 gene, we can make a determination about the carrier status. So if you look at the situation on the left, these are 2 different ways that parental testing could come back. If we suggest that the male's parents, that they both have 3 copies of the CYP21A2 gene, that his mother has the mutation and his father is negative, that's what we call non-informative. That doesn't really help us. We do know that the mutation came from his mother, but we don't know whether the extra copy came from his mother or father. And so in that case, it really wouldn't give us any more information. On the right-hand side, if we get lucky, you can see that his father has 2 copies of the gene while his mother has 3. His father's mutation negative and his mother's mutation positive. And this is informative because this tells us that we know he got both the mutation and the extra copy of the gene from his mother, which indicates that those 2 are on the same chromosome. So thankfully for this couple, that was the case, and we were able to say definitively that he was not a carrier and this couple did not require IVF and PGTM testing. It doesn't always work out like that. Sometimes the parental testing doesn't give you the information you're looking for. Switching to another example, sometimes you'll see increased carrier risk. We see this a lot with spinal muscular atrophy. Very brief review. I'm sure most of you are very familiar with spinal muscular atrophy. It's the second most common, lethal common genetic disorder in Caucasians, a very significant progressive muscle weakness and atrophy. There are different forms, but with the most common form, the life expectancy is less than 5 years. So I had another couple that I'll tell you about that I'll call the Smiths, and this couple is African American, and that's going to come up a little bit later in this example. And both of them came back up as increased risk for spinal muscular atrophy. So initially there's a big panic. They're both positive for spinal muscular atrophy is the way that it was presented to me by the physician that referred them. That's what they were under the impression. So let's talk about what increased risk of spinal muscular atrophy actually means. Spinal muscular atrophy is the gene that's involved is called the SMN1 gene. And like most copies of genes, most people have 2 copies, one on each chromosome. This particular disease, 95 to 98% of cases of this disease is caused by one single mutation. And that's very different than some other recessive diseases, such as cystic fibrosis, which could be caused by one of thousands of different mutations in the CFTR gene. In spinal muscular atrophy, most mutations are due to the deletions of exons 6 through 8 in the SMN1 gene. And so the way that this is tested for by the carrier screening labs is called dosage analysis, where they look for how many full functioning copies of the SMN1 gene does this individual have. 2 would be considered normal, 1 would be considered a carrier. However, we know that by just doing dosage analysis that we do miss some carriers. And that's because we can have something called 2+0 carriers. If you look at the diagram on the bottom right, you'll see several different ways that the SMN1 genes could be distributed on the chromosomes. In A, we see someone who has 2 copies of the gene, 1 on each chromosome. That's what we expect. That's traditional, normal, non-carrier. In situation B, we see someone that has 1 functioning copy on 1 chromosome and no functioning copies on the other chromosome. And that's what we typically expect to what we would call a carrier. But in situation C, we have a 2+0 carrier, which we see sometimes, especially in certain ethnic groups, where we see that there are 2 copies of the gene, yes, but they're both on the same chromosome, meaning that the other chromosome does not have any functioning copies of the gene. So even though this person would test normal by dosage analysis, they do have 2 copies, they're still a carrier. And if we only did dosage analysis, these carriers would be missed. And so what we've also learned over time is there's a particular DNA variant or single nucleotide polymorphism we call a SNP, the G27134T to G SNP, that we have learned tends to be more common in 2+0 carriers. So now we don't just do dosage analysis, but the labs also look for the presence or absence of this particular SNP. And the residual risk that someone will get after testing negative by dosage analysis is going to be very different if they have this SNP versus if they don't. So you'll see in the chart at the top where there's a red box around it, these are the residual risks if someone has normal dosage analysis tests, two copies of the SMN1 gene, but is also SNP positive. And so it's a lot higher than the residual risks that are given when they are SNP negative. Differs by different ethnic groups. In some, like the Ashkenazi Jewish population, it's extraordinarily likely that someone's a carrier if they're SNP positive. And in some of the other ethnic groups, it just increases the likelihood somewhat. So with this couple, they're both African American. So first we just sat down and we did the math. And I said, listen, there's a 1 in 83 chance that you're a carrier, a 1 in 83 chance that you're a carrier, and a 1 in 4 chance that if you're both carriers, you both passed on the mutation within a pregnancy. So if we do that math out, there is a 1 in about 27,000 chance that you would have a child with spinal muscular atrophy if we don't do anything different or any further investigation. So that definitely takes the level of anxiety in the room down quite a bit from this couple that understood or thought that they may have as high as a 1 in 4 chance, that we're talking about an extremely small chance that a child would actually be affected. That being said, they still are both considered at increased risk, and it's a horrible condition. And so there's still a level of concern. And the question is, what follow-up, if any, would we do in this case? You could consider parental testing, similar to like what we did in the last example. You would only, in this, you may or may not get what you want again from the parents. In this case, you would only need information that would at least show one of the two intended parents are negative or non-carrier, and then you would know you are not concerned for a child. You could also go straight to PGTM testing for those embryos. That is possible to do. And then what you could do is also say, you know what, I am comfortable with the residual risk of 1 in 27,000, and we're not going to do anything further. We're going to transfer the embryo or move forward with our reproductive treatment as planned without further testing due to the low risk. And that is what this couple decided to do. I actually was not able to find a live birth outcome on this couple, but I have a feeling that if a child had been born with spinal muscular atrophy, that we likely would have heard about it. Due to time constraints, I'm going to talk about this last one briefly and not go through the example. This is when you could actually have a difference between carrier screening results. And there's several different ways that this could happen. In some cases, you can have a patient that did carrier testing through 2 different labs, and one of them showed that the patient was a carrier of a particular disease, and the other said the patient was negative for that same disease. I've had that happen multiple times. Can often be based on the way that the individual lab classifies that specific variant. You can also have a discrepancy between DNA testing results and enzyme results, and in that we can see in Tay-Sachs or Sandhoff disease. So just reviewing Tay-Sachs, very serious degenerative neurological disease, most common in the Ashkenazi Jewish, French Canadian, Irish population. And you can test by either DNA mutation testing or enzyme testing, as we expect carriers to have a reduced level of the beta hexoamidase A enzyme. So years ago, when they did DNA testing, they were doing genotyping when we were just looking for specific known variants in the Hfe gene. And those variants, the way we learned about those variants was really through the population that had been studied most significantly for Tay-Sachs, which is the Ashkenazi Jewish and European, Caucasian in general population. So when we were doing genotyping, there was the thought that if someone is a Tay-Sachs carrier, but they're of a different ethnic group, the detection rate may not be so great, because it's likely that in other populations there are other deleterious variants in this gene that maybe haven't been identified and therefore aren't being looked for by genotyping. For that reason, at that time especially, enzyme testing definitely made a lot of sense as a second check. Today, DNA testing is done pretty much everywhere by next generation sequencing, which is not just looking for known specific DNA variants, but is looking for unknown variants and is looking for predicted variants and really reading the gene. Really should perform fairly equally across different ethnicities. The labs now quote a greater than 99% detection rate for DNA testing across the ethnic groups. But based on guidelines still being the guidelines from ACOG being a little bit unclear and what clinics are used to doing, a lot of clinics are still doing both DNA mutation testing and enzyme testing on their patients. In a lot of cases, that's great. If you get a consistent result, then you can be even more confident in that result. But you can have results where the patient is negative via DNA testing and appears to be a carrier via enzyme testing, and then you have to sort of figure out how you're going to figure out if the patient is or is not a carrier in that situation. I was going to go through an example, but I think I'm going to skip over it because I really want people to have a few minutes for questions. I'd be happy to talk further, but you can just see my patient's results on the right hand. That's just showing an inconsistent result where he was a carrier of Tay-Sachs. There was no mutation detected, but the enzymes were in the carrier range.
Hi, everyone. So it looks like there are no questions in the question box at this time. So just make sure to get your questions in. But that was a great job from our speakers. Thank you all. I have a question to start. Lauren, this one's for you. Do you think that current professional guidelines, since you were talking about professional guidelines, do you think that they're really keeping up with advances in carrier screening technology?
I think the fact that both ACOG and ACMG have published statements that address kind of the appropriate use of ECS is very important. I think at the end of the day, most providers, I would say, are not just testing for ACOG and ACMG guidelines, but going sort of beyond that. I don't know if we will get to the point where the professional societies actually recommend expanded carrier screening, but what I will say is there's a growing body of evidence and research that really does support that pan-ethnic screening model because of newer technologies like next generation sequencing, which allows us to sequence the entire gene versus just look at targeted mutations. It really is a more equitable form of screening when we talk about different ethnicities, getting different types of tests. And I think just in the last 3 to 5 years, we've seen a lot more literature and data come out about that. So I hope in a few years there will be enough for professional societies to reconsider guidelines, but the wheels move slowly, so I'm not totally confident we'll see that in a timely manner, but I think it's important to be aware of what the industry is doing, and that expanded carrier screening really does carry a lot of benefits to patients.
Definitely seems like the technology is really outpacing what professional societies can even really keep up with.
Right.
Another question that I had for Amy, how would you counsel patients who are manifesting carriers of recessive conditions in terms of reproductive options? Is it something that you talk about prenatal testing or PGTM for, assuming if the other partner is negative for that condition?
Definitely, because if that patient would be at 50% chance of passing on that gene that could manifest carrier, that could manifest in a disease in the offspring, and I would definitely talk about the option of PGTM or prenatal diagnosis with them.
Okay, great. There is an audience question. So the question is, does anyone know of any guidelines for fertility clinics when one partner is a carrier and the other partner is untested? So this individual says, I consult for a sperm bank and I'm speaking to quite a few recipients who are being required to test, no waiver allowed for risks that are very, very low. So presumably for very rare conditions where one person is a carrier and the other person hasn't been tested, but the chances that they would be a carrier would be pretty low. Are there any guidelines surrounding that?
I don't think that there are guidelines. Well, there are guidelines for gamete donors, and the gamete donor guidelines, they're newly published, so I might not know them, word by word, but the general feeling of the guidelines is that if one person is a carrier, the other person should be tested and negative for that condition. Those are it's the general feeling of the guideline. The guidelines are directed at the gamete donor, so the way that the old guidelines anyway, the way they were worded was that if the donor is a carrier, but to me, you could infer that it would read the same way if it was the partner that was a carrier. And really, I think that a lot of genetic conditions are rare, and let's just say you have a 1 in 100 chance of being a carrier for a particular condition. When the other gamete provider is a known carrier, the risk for an affected offspring goes up quite a bit. And really, it just, in terms of sort of common sense and good medical practice, it doesn't make a lot of sense to skip a step at that point, in my opinion.
And I'll just add to that, I don't think that, having worked with several gamete banks as well, I'm not sure that the guidelines, like Amy was saying, they sort of suggest that that's what's recommended. I'm not sure they're set in stone, and I think that each bank or clinic has their own system or how they handle that. But I will say that both of the gamete banks that I work with have, when either the donor or the intended parent are carriers, they have some type of waiver that indicates we strongly recommend that you be tested for the known condition the donor is known to be a carrier of, but they do have the option to sign something that says they understand there's increased risk and decline testing.
And our clinic has that too, very similar, where we certainly do recommend it ideally, because even rare things, can happen and do happen. So we definitely recommend it, but sometimes it's not possible, and do give the option to waive. Jamie, a question for you. How can clinics who don't have an in-house genetic counselor ensure that they're not missing something important on the carrier screening report?
Yeah, so it's a good question. I think hopefully this webinar is somewhat helpful on identifying some of the things that maybe when you see should be kind of a red flag that, oh wait, this might not be that simple. I need to look a little bit more carefully. I need to get some genetics professionals involved. But you all have access to genetic counselors, and really use the genetic counselors in these scenarios where it's not completely clear to you what your patient's results mean. All of the carrier screening labs have genetic counselors on staff that will work with you. There are lots of genetic counselors in private practice or that work with telegenetics companies that can help you. More and more clinics are hiring in-house genetic counselors because there are so many situations like these with their patients that are really complex. So please, if it's not completely clear, ask a genetic counselor.
It looks like this question is for Amy. It says, can you speak more about the opinion to screen men for X-linked disorders? This individual says, I hesitate doing so as it feels more like a diagnostic test, though I do understand the reproductive implications if positive.
Yeah, it's true. It was just that case that I had really made me think about that this person was really potentially going to benefit from this knowledge. Maybe not so much for reproduction, but for his own health. And that isn't the goal of carrier screening. But I was mostly highlighting that as just something to consider. But it isn't the direct goal of carrier screening, because you're right, it would be more like diagnostic testing.
And Amy, while we're still on you, there is another question about manifesting carriers. So it's really a comment, but also kind of goes with a question that I had. It says, I'm concerned about the addition of personal cancer risk genes without pre-test counseling, and wonder if industry is going to try to get other similar genes. So we're talking about the cancer risk genes like ATM and NBN and FH, if the industry is going to try to get BRCA on there one day. And that kind of goes hand in hand with my question, which is, do you feel like patients are prepared to receive that type of information when they get carrier screening?
Yeah, I mean, I'm concerned about it too. And I mean, I can tell you that regarding even just taking a step of before I was willing to adopt at a clinic that I work with a large carrier screening panel, I really dug my heels in and just said, we have got to have verbiage at the very least that people are at least somehow aware of the fact that there may be certain genes on these panels that could affect their risk. And so I'm concerned about it as well. BRCA, those types of cancer genes are autosomal dominant, and so those genes would not be showing up on carrier screening panels. But that's not to say that the ATM and NBN and other genes on the panel don't confer cancer risk. So I'm not concerned about like BRCA and other autosomal dominant type where family history is driving someone to get tested. But I think overall, the manifesting carrier chunk of genes is delicate and needs a lot of attention to detail and detailed counseling and care, so that people really do understand. You know, and if you get one of those type of results where, you know, you as the provider are kind of blindsided, just as the patient will be with this test result, those are good. Those would be some good choices to really possibly refer to a clinical genetic counselor.
Does anyone else on the panel want to add anything? If not, I'm going to direct the next question to Lauren. Lauren, how static are carrier screening results? Should a patient ever be retested once they've already been tested?
That's a great question. And the answer is, there's a couple of different ways I can answer this. So first of all, our DNA and our genes don't change. So if you have a mutation, you were born with it, you're going to die with it, you always have it. Your mutation status doesn't change throughout your lifetime. What does change is technology. And so it's possible that somebody who went through carrier screening with an older technology carries a mutation that just wasn't picked up at the time that specific technology was being utilized. Again, I mentioned before, technology's come a long way. Next generation sequencing is standard, so we can actually look at the entire gene, and we can look at a larger number of genes at once. And so I would say if someone has been tested, you know, 10 plus years ago, it certainly may be worthwhile to offer them an updated carrier screening panel with new technology. And I would say again, you know, if you're, as a provider, you're unclear on if it's warranted to repeat carrier screening, definitely utilize your friendly genetics professionals who can take a look at that report and maybe evaluate what technology was used, what genes were tested, how many mutations were covered, and see if it would be appropriate to repeat testing on a patient, because sometimes it really is. So yeah, that's a really good question.
And a great answer, thank you. I'm going to just ask the one last question here, just because I know we are already over on time, and thank you panelists who are willing to stay a little bit late, but there's an interesting question. I'm going to try to summarize it because it's a little bit long, but about a patient who is using anonymous donor sperm and wants to do comprehensive carrier screening, but doesn't actually want to know her results unless the donor is a carrier for the same condition. So I guess just in general, does anyone have any opinions or want to give any guidance on situations where patients just in general may not actually want to know the results, maybe from the get-go, or once they get that call with results and maybe they get anxious and don't want to hear about them? Does that ever come up in your clinic?
I know there's a program, the Doria Shoreham program, I believe, in the Jewish population, where essentially they do that they do carrier testing on people and don't tell you what you are and are not a carrier of, just say, are you a good match? Are you a carrier of the same thing or not? So that's interesting. I will tell you that in 10 plus years of working in an IVF clinic, I have never had a patient tell me that they didn't want their results. I don't know if anyone else has a different experience.
No, I've been a genetic counselor for 30 years, and the only instances where I have had patients not want to know their results related to something like Huntington's disease, where that was a very tragic, it would be a diagnosis for that person. But for carrier screening, I've never heard that. I think it would be a possibility. The only thing that I can think of that could be a little tricky is if there was something like a manifesting carrier gene that came back, it would be, you would have to prearrange how you were going to deal with those kinds of things, because you could basically be withholding information that could be important to their medical management, and that could be a little bit tricky.
Just one more thing to add to that. I would also say it's the genetics professionals, it's our job to figure out why the patient doesn't want to know their results, and if they truly understand what being a carrier is, how common it is, that in most cases it's not a clinical implication for their health. I would say that if I had a patient who asked that, I'd wonder why she didn't want that.
Mm-hmm.
Yeah, that's a great point. Well, I think we're going to wrap up now. So I just want to thank our panelists and thank ASRM and thank our audience for being so engaged. Thanks, everybody.
Thank you. Bye, everybody.
Well, thank you, Andrea, for moderating such a fantastic session. And thank you to our panelists for bringing such an important topic up for discussion. And to the attendees, thank you for joining us. This session was recorded and will be available on our website in the near future. Please watch your email for notification about future webinars. And for any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar.